Falls in the Elderly by Courtney Odom. After watching this presentation about falls in the elderly, the student will be able to identify common risk factors associated with falls, identify the different fall assessment tools, and understand how to use each of them, and be able to identify nursing interventions to prevent falls in both the acute care setting and in the home setting. This is usually the mental picture we see when we hear of an elderly patient falling. Though she may not appear to be hurt, there are many serious injuries associated with falls that aren't always visible on the outside. According to the Centers for Disease Control website, more than 1 in 4 people over the age of 65 fall each year, with less than half of those reporting the fall to their primary doctor. That's a very large number when put into perspective. Just think, when at church, probably 25 to 30 people, depending upon the size of your church, of course, have fallen or will fall within the year. 1 out of 5 falls result in serious injury, such as hip fractures, head injuries, or other broken bones. An estimated 3 million older people are treated in emergency rooms for injuries resulting from falls. Over 80,000 elderly over the age of 65 are hospitalized for falls each year. That's a lot of resources being used for something that can be prevented with the right tools. From the years 2007 up until the year of 2016, the death rate from falls in the United States increased by 30%, according to the World Health Organization website. That makes falls the second leading cause of accidental or unintentional injury deaths worldwide. Some of the risk factors we'll learn about in this presentation are the patient's medical history, age, mental status, acute medical conditions affecting the patient, medications the patient may be on, and gait, balance, and strength. Some medical problems that can increase the patient's risk for falling include vertigo, postural hypotension, hypertension, visual disorders, syncope, epilepsy, and arthritis. Vertigo is a common condition we think of when we think of a medical condition that causes falls. Vertigo causes patients to lose balance, therefore making them at an increased risk for falling. Postural hypotension, also known as orthostatic hypotension, is caused by the patient rising from sitting to standing position and experiencing a drop in their blood pressure. This can cause the patient to feel dizzy, leading them to fall. Hypertension in itself could cause falls in a number of different ways, including the patient feeling effects from a headache from the blood pressure being so high to the medication taken for hypertension, which can cause the patient to be orthostatic, which is also known as postural hypotension, as discussed before. A few visual disorders that could increase the patient's risk for falling could be cataracts and glaucoma. Both can create a visual deficit causing the patient to fall. As Dr. Hummer mentions in her previous lesson, cataracts is a leading cause of blindness in the U.S., and we all know the effects of blindness on falling. Syncope can be caused by a number of things, but from my previous experience, the one of the most common concerns related to syncope is cardiac. Syncope is defined as partial or complete loss of consciousness with interruption of awareness of oneself and one's surroundings. Most times we see people come into the ER for syncope and fall, especially the elderly, because they may have other conditions that increase the risk for falling, which a younger person may not have. Usually, what saves an elderly person from falling when they have a syncopal episode is family or a friend being nearby to catch them, or them being near a chair or a bed to fall back on. Epilepsy is another medical problem that increases the patient's risk for falling. The CDC defines epilepsy as a broad term for a brain disorder that causes seizures. Seizures can cause people to steer off, known as absent seizures, but can also cause people to collapse, shake, and become unaware of what's going on around them. Arthritis is the last medical condition that we'll talk about. Arthritis can cause an increased risk for fall due to the stiffness and pain associated with it. Arthritis is known as pain and stiffness in the patient's joints. If an elderly person experiences arthritis, which from my previous experiences, most do, this could cause their joints to not work as they should or cause it to be more difficult for them to move than someone without arthritis. This could cause the patient to fall if they intend on moving a certain way and their body does not cooperate. Some acute medical conditions that can increase an elderly patient's risk for falling are recent surgeries, wounds, ear infections, acute onset of confusion related to a UTI or any other infection, and acute onset of motor deficits. Recent surgeries such as a knee or hip replacement, and any other surgery for that matter, can increase the patient's risk for falling. Obviously, a knee or hip replacement would cause a change in the person's ability to walk normal. However, that may be for the patient prior to the surgery. Other surgeries could also increase the risk. One, from the anesthesia that was given during the procedure, whether it be general anesthesia or a form of spinal block. And two, the pain from the surgery could increase the person's risk from falling. Wounds could increase the person's risk for falling because they could impair the patient's normal ability to walk, especially if the wound were on the feet or the legs. Ear infections are a common acute medical condition that could cause the patient to lose balance and thus also cause that patient to fall. An acute onset of confusion caused by a UTI or other forms of infection could increase the patient's risk for falling, especially if the patient is no longer oriented to his or her own ability. When I have a patient that is not alert and oriented, it is triggered in my mind immediately that that patient will be at a higher risk for falling. An acute onset of a motor deficit or deficits could place the patient at a higher risk for falling. One cause of an acute motor deficit or deficits that comes to mind is a stroke. According to the CDC, someone in the U.S. has a stroke every 40 seconds. After learning about that number, stroke should immediately trigger the falls risk on each patient that they affect. Medications that increase the elderly patient's risk for falling include tricyclic antidepressants, antihypertensives, cardiac medications, and hypoglycemic agents. Tricyclic antidepressants can cause drowsiness and sedation, therefore causing the patient's risk for falls to be increased. Antihypertensive medications have a goal of decreasing the patient's blood pressure, but if the blood pressure is decreased too much, it can cause dizziness. Also, antihypertensive can cause orthostatic or postural hypotension, like we discussed earlier. Cardiac medications oftentimes work to decrease the patient's heart rate, which can also decrease the patient's blood pressure. A decrease in the heart rate, lower than the patient is used to, can cause a syncopal episode, thus increasing the risk for the patient falling. Hypoglycemic agents work to decrease the patient's blood sugar, but if decreased too low or too fast, the patient can experience symptoms that mimic a stroke, causing slurred speech, weakness, and mental status changes. Weakness and mental status changes obviously can cause the patient to be at a higher risk for falling. Hypoglycemia can also cause a patient to lose consciousness, which would also obviously cause the patient to be at an increased risk for falling. Physical changes that can increase a patient's risk for falling include gait disturbance, loss of balance, and decreased or loss of strength. Gait disturbance and loss of balance can be caused by a number of things, such as anesthesia, wounds, vertigo, to as simple as the patient not having on the proper footwear. A decrease or loss of strength can come from a number of medical conditions. If the patient is not strong enough to support the weight of their body, then they are at an increased risk for falling. Next, we'll talk about 4 tools for assessing the patient's risk for falling. These include the Time Up and Go test, the Morse Fall Scale, and the Hendrick II Fall Risk Model, and the St. Thomas Risk Assessment Tool in falling elderly patients, also known as the Stratify tool. The Timed Up and Go test is a test performed to determine the patient's risk for falling. The person administering the test will need a straight back chair with armrests, proper footwear for the patient, and any assistive devices that the patient may need. The patient sits back in the chair. The test administrator times the patient rising from the chair, the patient walking 3 meters, turning around, walking back to the chair, and then sitting back down. The person administering the test does not help the patient physically in any way, unless, of course, the patient's safety becomes at jeopardy. A score of 10 seconds or less indicates the patient is freely mobile. A score of less than 20 indicates the patient is mostly independent. A score of 20 to 29 means the patient has variable mobility, and a score of 30 or greater indicates the patient has impaired mobility and is at an increased risk for falling. The Morse Fall Scale was published in 1989 and is widespread used in the United States. According to Natalie Callis, the instrument was created to have an acceptable sensitivity value of 78%. In 2007, it was tested by Ang et al. And found to have a sensitivity value of 88.3%. The Morse Fall Scale used the categories history of falling, secondary diagnosis, and ambulatory aids, IV, saline lock, gait, and mental status to determine the patient's fall risk. A score of 25 or less indicates low risk, 26 to 50 indicates medium risk, and 51 or greater indicates a high risk for falling. The highest score possible is 125. The Hendrick II Fall Risk Model is another relatively quick tool used to determine a patient's risk for falling. According to Callis, it was published in 1955 and was updated in 2003. It was established with an acceptable sensitivity value of 74.9%. This same study mentioned previously by Ang et al. Found a sensitivity value of 70%. The Hendrick II Fall Risk Model uses the categories confusion or disorientation, depression, altered elimination, dizziness or vertigo, gender, administration of antiepileptics or benzodiazepines, and get up and go test or ability to rise in a single movement test. A score of 0 to 4 indicates a fall risk of low, while a score of 5 or greater indicates a fall risk of high. The highest score for this assessment tool is 15. St. Thomas Risk Assessment Tool in Falling Elderly Patients, also known as the Stratified Tool, is a tool that I was not very familiar with. It was published in 1997 with an established acceptable sensitivity value of 93%, according to CALIS. When tested by Ang et al. In 2007, its sensitivity value was only 55%. This tool uses the categories history of falling, mental status, visual impairment, frequent toileting, and transfer mobility. Low risk is indicated by a score of 0 to 1, and high risk is indicated by a score of 2 or greater, with 5 being the highest possible score. According to CALIS, out of the Morse Fall Scale, Hendrick 2 Fall Risk Model, and the St. Thomas Risk Assessment Tool, the Morse Fall Scale is the most sensitive in determining the patient's risk for falling. This is reassuring because as of October 1st, my hospital switched from the Hendrick model to the Morse Fall Scale in wake of our EPIC transition. When thinking about nursing interventions for falls, there are tons that come to mind. Some we will talk about today are keeping floors clear and free from clutter, using bed and chair alarms, using side rails as appropriate, ensuring wheels are locked on beds and chairs, placing fall bands on patient's arm, and appropriate signage on the door or in the room, reorienting patient as needed, offering assistance frequently, and keeping personal items within the patient's reach. Most of these are self-explanatory, but we'll go over them briefly. Keeping floors clear of clutter should include footwear not in use, as well as equipment and cords that could be laying around. Using bed and chair alarms can be very helpful and can meet the sensitivity of all patients, from letting you know if the patient even moves to only letting you know if they rise from the bed or the chair. We all know the importance of side rails and that we may only keep 3 up at a time unless we're using the fourth one as a restraint and charting appropriately if that's the case. Keeping wheels locked prevents the chair or bed from sliding out from under the patient. Placing a falls band on the patient and appropriate signage on the door or in the room lets other members of the healthcare team and visitors know that the patient is at an increased risk for falling and that the patient will need assistance when exiting the bed or chair. Reorienting the patient helps them to be aware of where they are and what's going on and remind them of the need to call for assistance. Offering assistance helps to prevent the patient from trying to do things alone and falling as a consequence. Keeping personal items within reach is another way to help decrease the patient's risk for falling because they don't have to get out of bed to get items they may need. In my experience with falls I've heard about at my hospital, most patients' bed alarms were not turned back on and patients were reaching for personal items. The tips to preventing falls at home are the same as they are in the hospital, such as preventing clutter and keeping personal items within reach. Some other tips to preventing falls at home and to educate family and patients are removing throw rugs, installing railing on steps and in restrooms, using assistive devices as needed, ensuring adequate lighting, and another helpful tool would be to get the patient a life alert or similar necklace. Removing throw rugs will prevent the patient from falling over. In my experience, elderly patients don't always pick up their feet when they're walking, increasing their risk for tripping over rugs. Installing rails would help prevent falling on steps and would help reduce the risk of falling in the restroom, especially when entering and exiting the shower. Using assistive devices as needed will give the patient more stability when walking. It is important to have adequate lighting so the patients can see where they're going and if there are any hazards in their way that they need to be mindful of. Lastly, getting a life alert would help more so after a fall, but would be good to include in fall education, especially if the patient is going to be home alone at any point. In that case, the ambulance could be called in case of an emergency, and they could be assessed and sent to the hospital as soon as possible. I feel that education is one of the greatest tools to preventing falls, at least in my opinion. Educating healthcare staff as well as patients and families is a great tool for decreasing the number of falls and in turn decreasing the number of fall-related injuries seen in the elderly patients. In the end, this would not only save elderly patients injuries, it would save tons of money across healthcare.